medical officer. It has to have registered nurses who must supervise continuous nursing care. It also must be governed by a board and must employ a full-time chief executive officer to manage the operations. Now, the hospital CEO, chief executive officer, could have other titles depending, of course, on the size of the hospital. Usually, large medical systems or integrated delivery systems, as we will be talking about later, is governed by or headed by a chief executive officer. Now, the hospital must also maintain medical records, and it must have pharmacy services on campus. Services should be available, and it should also provide food services. Now, hospitals are meant for inpatient healthcare services, and inpatient care refers to an overnight stay in a healthcare facility, in this case, a hospital, so therefore it could also be a nursing home. So when the patient is formally admitted with a physician's order, the admission has to be signed off by a physician. In cases like, for instance, if you get admitted into the hospital through the emergency room, then the admitting physician normally would be the emergency room physician, and then you are endorsed to a house staff or a hospitalist. Now, the construction and operations of a hospital are governed by several laws. There are federal laws, there are also state health departments regulations, there are city ordinances, then of course we will talk about the Joint Commission. There are fire codes, which are usually, actually not usually, but standardized as a federal code. So the fire codes are always federal standards. And of course, regulations for sanitation. Now, it is the state health department that provides the licensing for hospitals. Now let's talk about the evolution of the hospital in the United States. Before 1850, almshouses, also known as poorhouses, were the main healthcare institutions and were run by local governments. Services in these institutions were very much similar to social welfare than formal medicine or the provision of medical services. And it consisted mostly by giving food and shelter to the very poor, the destitute, and some nursing care to the sick. There were only very few hospitals that existed, and most of them were found in major cities at that time. The second stage in the evolution of the hospital happened during the latter half of the 1800s. Hospitals began to transition from being primarily government-run institutions to community-owned institutions, and they were supported mostly through contributions raised through charity. And many wealthy donors were the ones that provided the financing, but despite the fact that the financing came from the wealthy members of the society, hospitals at the time were mainly serving the very poor. And as a matter of fact, that was the main purpose, was to serve the poor. Stage 3, this is when we started seeing the modernization of healthcare in the US. And this was brought about by discoveries in medical science like anesthesia, surgical techniques, antiseptic and sterile procedures, X-ray, and other diagnostic tools. These all transformed hospitals into institutions of medical practice and training. And as I've explained also earlier, previously when we were talking about the history of medical training in the US, hospitals became very important because they became the repository of this advanced technologies at the time. Now, stage 4 saw the emergence of small proprietary or for-profit hospitals, and they were opened by physicians. So further advancement in sanitation, professional nursing, medical services uh, came about because it was also during this time that advancement in medical technology was happening. And it was also during this time that the rich people started, well-to-do members of the community started using hospitals. There was like a growing uh, belief in the populace, especially those who were rich members of the society, that they indeed can actually rely on hospitals for care. And it was also at this time that hospitals started not being solely dependent on charitable contributions, because at this time, when people who had money started using hospitals, they were able to pay for the services that they were getting. In stage five, this was when the advancement of educational reform in medical education happened in the United States, and many hospitals began affiliations with universities, and then hospitals became complex organizations, and the way we see the structure of how a hospital is managed nowadays started to form during this time, and hospital administration became a formal discipline. Stage six is currently what we are seeing. This was when market pressures have prompted hospitals to form affiliations in the form of mergers and other formal affiliations, which then created health systems in large urban areas. And these health systems or medical systems are also known as integrated delivery systems. So there are two types of integration that led to the formation of larger medical systems. Horizontal integration is defined as the coordination of activities across operating units that are at the same stage in the process of delivering services. So these are organizations that basically deliver or have the same type of services, and they basically band together, such as hospitals, medical centers merging together, not really diversifying the types of services that they have to offer. And it turned out not to be that profitable. What turned out to be most efficient and profitable was the vertical type of integration. Now, these are organizations that deliver a variety of services. And this type of integration basically aims for more efficiency, more outreach, because of the different levels of services they have. This happened with hospitals acquiring freestanding clinics and facilities. So there would be the main hospital campus, but there would also be outpatient departments that are affiliated. So think about Montefiore or Mount Sinai or Columbia Presbyterian. They have the whole gamut of the type of healthcare delivery service facilities. And this turned out to be more profitable in the long run. Today's hospitals are quite complex. And not only do hospital administrators, especially those who are on top, the CEOs, need to understand the clinical aspect of a hospital or a medical system operation, but they also need to be trained in financial management. And that is the reason why most CEOs, if not all, in terms of the large health systems or integrated delivery systems in large cities, they are all physicians. So they have the clinical background and training, and yet they have additional training in hospital administration, which requires additional training in financial management. Now, what really prompted the formation of integrated delivery systems was market pressures. So there was a need to lower down the cost and make healthcare delivery services more cost effective. Let's talk a little bit about the expansion and the downsizing of hospitals. So these are quite historical, but all of these, the Hill-Burton Act, the creation of Medicare and Medicaid, they were the main contributors of the expansion of hospitals in the United States. In the 1980s, when it was getting quite evident that the cost of healthcare was rising consistently, um, policy experts started to look for solutions. And we talked about prospective payment systems and the DRGs, diagnosis related groups. This led to cost cutting and quicker discharge of patients. So there was a lot of downsizing that happened. And further on in the 1990s, managed care became much more like a norm in terms of the way healthcare services were managed. And it resulted in bringing down inpatient utilization, meaning hospitalization, and a lot of emphasis of managed care went to either early discharge. This resulted, of course, and basically early discharge was done under the general guidance of diagnosis related groups. And it also shifted to outpatient services. And both the prospective payment system and managed care basically led to the desired effect of tamping down, if not controlling, the increase in hospital expenditures.